have Dr. M. Ram Prabhar. He's a director and senior consultant nephrology, Institute of Renal Science and Transplantation, SIMS Hospital, Chennai. And he will be talking about living well with CKD anemia. Over to you, doctor.
I couldn't see my slides. Can you put it?
Okay. We'll just be sharing in a minute.
Yeah. So good afternoon to everyone. First, thank you so much, the Kidney Warriors Foundation, for having given me this opportunity to speak in this forum. And it is a World Kidney Week, and I know everybody is bombarded with a lot of information regarding kidney disease. Yeah. I'll do my part to impart some knowledge about kidney disease, what is the present status in India, and what we should all do to prevent it from reaching an explosive situation. So with that words, let's move on to the topic proper. So I have labeled it as like kidney disease, act now or pay later, just to impart the important point that kidney disease is like a silent epidemic, and the numbers keep going up. We must act together to prevent it from reaching huge proportions. Next slide. So I'm basically an previous slide, please. I think okay. So this I am basically a nephrologist, and this is basically an awareness lecture. I did put some medical terms, and I thought it is my responsibility to share scientifically proven data on kidney disease. Since it is a patient-related forum, I have to admit here that I'm not completely sure what is expected of me at the same time. Next slide. So the topic goes like this. I will share some facts about India, because this topic is about CKD in India, our health status, what is the burden of kidney disease, how do you identify kidney disease, and what are the risk factors, and how to prevent and treat CKD, and the last few slides about anemia in CKD. Next slide. So India as a country we had less than 3% of land mass, but we have a population close to 17% of the whole world population. And our data goes back even at 2011 census goes to 1.2 billion, but at the moment it appears that we are at 1.4 or 1.5 billion population. And we are still a poor country, low middle income country, where 3/4 of our population still live in rural areas, where annual per capita income is less than $500. And we have a very huge number of population which is living on the below poverty line. And still we are yet to overcome even our basic nutrition, sanitation needs, that resulting in childhood malnutrition and so on. Next slide. So in terms of spending for healthcare in India, if you look at this, in the Indian public healthcare expenditure still remains around 2%. I will be showing you the slides. And whereas the world average in the developed world is around 5 to 6%. So with the financial limitations we have, there is always a capacity crunch in the public healthcare system, because we don't get enough allocation for healthcare, because we have so many things to attend to, being a very poor developing country. Next slide. So this is a data that I have taken from the site about the need or the problems in payments in healthcare sector. Next slide. So it appears that quite a bit of population in India is meeting the expenditure by out of pocket. This is actually a graphic which is taken from just published economic survey data from this year. Just you can see the curve. The previous slide, please. Yeah, so this is the data. The orange colored one is the expenditure by the government, and the blue line is the out of pocket expenditure from the patient or the family itself. You can still say compared to our government, still we are spending more from out of pocket. That makes a lot of people poor. As I told you in the previous slide, you can clearly see almost 7% of our population is pushed below poverty line just because they are forced to spend so much on healthcare out of pocket expenditure. Next slide. So this is the data. Next one, click, it will highlight the expenditure. So this is the one which I am talking about. So you look at this health expenditure in terms of total budget. In the year 21-22, when we had COVID, we had a good allocation of 3.5%. But if you look at the next 2 years, subsequent years where the COVID is settling down, we are going back to the old numbers around 2% in terms of healthcare expenditure. This is the real problem, unless we improve the allocation to healthcare, we won't be able to deliver in terms of public healthcare in India. Next slide. So if you compare this with the urban versus rural, public versus private, you can still say we are thriving more on the private healthcare than compared to the public healthcare. You know that private healthcare is very expensive and it is beyond the reach of an average common man. So this is what I wanted to insist on. Next slide. So about the Indian disease status, now we are moving from where we are seeing many infection related diseases to non-communicable diseases. So previously, as we were poor and underdeveloped countries have a lot of infectious diseases like malaria, tuberculosis, acute diarrheal disease, some respiratory disease, and so on. From here, as we get our basics right, we are getting into lifestyle related diseases, particularly non-communicable diseases. And most of these focus on cardiovascular disease, diabetes, and hypertension. And you are very sure, most of the people who are listening will know that at least some of their family members will have some form of diabetes, hypertension, or heart disease. But what we are not focusing on is the impact of chronic kidney disease. So it is not the kidney disease that we worry about. It is associated with so many consequences in the population in terms of increased hospitalization rates, increased morbidity, mortality, end-stage kidney disease, cardiovascular disease, and so on. So it is just a whole package which you need to think about rather than just saying, I have a kidney disease. What is the problem? The problem is it leads to so many problems that lead on to complications and loss of lives. But it is not given its enough attention. Next slide. So this is the slide which I have been talking about the Indian scenario where we are seeing in the low middle income countries, we are slowly taking away from the communicable diseases to non-communicable diseases. Next slide. So the deaths attributed to infectious disease is declining, whereas the deaths attributed to chronic disease is increasing almost 2 to 20% more than our stock markets. Next slide. So if you look at the death rate from chronic diseases in India, if you look at the numbers, you can see India almost in the middle of most of the developing world. Next slide. Coming to kidney disease burden across the world, if you look at the kidney disease part, this is the data which is from global burden of kidney disease. You can clearly see the prevalence of kidney disease is increasing by 9.1%. At the moment, we have close to 700 million cases. That is close to 70 crore population of kidney disease patients across the world. Global prevalence is around 9.1% and keeps growing by almost 30% from the year 1990. Next slide. So India is the diabetes capital of the world, because if you look at the prevalence of diabetes, they're going up in India close to 70%. So the Southeast Asia is represented in the middle. You can clearly see India is coming just next to China in terms of diabetes prevalence. It is likely to go up by another 55% by the year 2035. This is more important in terms of kidney disease perspective, because diabetes is the leading cause of kidney disease, even in Asia Pacific region. Next slide. So if you look at this chart, you can clearly see, look at where India is. Almost 35% to 40% of our diabetic people have some form of kidney disease. Though it is less common than the Singaporean population, other Southeast Asian nations, still it may be sheerly because of not awareness and not screening our population for presence of kidney disease. So definitely diabetic kidney disease is very highly prevalent in our population. Next slide. So this is important because you just see what is the cost of kidney disease care. It becomes too expensive to keep anybody with kidney disease on medical treatment. Just see, this is the Western data, not even Indian data, just published a few months ago. You can see the most of the developed world, the cost of kidney disease care is more than treatment for cardiac failure, heart attack, strokes, peripheral vascular disease, and so on. So it is making nations to sit together and start about what has to be done for curing kidney disease. Next slide. So what is this kidney disease? Next slide. Okay, so previous slide, one more it has gone. Yeah. Okay. So for people, layman, people, when we say CKD or chronic kidney disease, what is it? That needs to be known. So the CKD means the progressive irreversible loss of kidney function. Means you have a disease which is likely to progress and you have an irreversible stage. It is not going to improve with treatment. That is where we say it is chronic kidney disease. So how do you diagnose a CKD in a given individual? This is based on a blood test called serum creatinine and an estimation of kidney function using estimated GFR. So this GFR, or called glomerular filtration rate, is the marker of kidney function that is estimated from serum creatinine based on the markers. About kidney disease, it evolves through various stages. Generally, we have stage 1 to stage 5 based on the GFR, and the stage 5 is called end-stage kidney disease. Next slide. So this is the medical definition. Let us don't harp on about how medically CKD is defined, but I've told you how to define a CKD in a given patient. Next slide. So it is important. Next slide. Okay. So it is important to understand CKD is a progressive disease, not a static disease. I told you it has 5 stages based on estimated GFR. It goes from stage 1 to stage 5. The stage 5 is called end-stage kidney disease, where people land up in some form of kidney replacement therapy. Next slide. So this is the numbers of GFR based on which various stages of CKD is staged. Less than 15 when the GFR goes, it is called kidney failure. To the next slide, we have just shown an tip of the iceberg. What we identify in clinical practice many of the time is stage 4 or stage 5, whereas huge amount of population in the earlier kidney disease stages were not even identified. That is where the problem lies. If you identify only an early kidney disease, we can put brakes on the progression of kidney disease and prevent from reaching end-stage kidney disease. But unfortunately, we really look after only the tip of the iceberg, missing the submerged portion. Next slide. Next slide. So even in India, you can see there is huge increase in CKD prevalence. If you look at the epidemiology, there is more than 40% increase in deaths due to kidney failure. Many people who are dying of heart disease have associated kidney disease, but not many people focus on that. If you look at the overall prevalence of kidney disease in India, it varies from 1 to 13% depending on the region, depending on the study. Next slide. So we don't have a registry in India. In other countries, patients on kidney disease are registered properly and their data is analyzed. Here, we don't have a registry. So we actually have only few studies from across the regions. Next slide. Next slide. So next slide, please. So this is the various studies that have been published in the last decade or so. You can see most of the time, the population prevalence of kidney disease somewhere lies between 10 to 11% if you look at the average of most of the studies. So that is the number we are looking at. So if you see 100 100 general public, you can see at least 10% of them have some form of chronic kidney disease measured by the tests. Next slide. So it is very, very important that early stages of kidney disease are identified, because early stages are asymptomatic. Less than 10% of people are getting screened for kidney disease. Many times we see patients only at end-stage kidney disease, and less than 25% receive any form of treatment at earlier stages. So it is not only in India, most of the even developed world did not recognize early CKD. That is the problem as of now. Next slide. So this is the data which says how many percentage of people are not even tested. Almost 50% not even tested. And another 30-35% appropriately tested but not given proper diagnosis. Only some 10 to 12% receive appropriate testing and accurate diagnosis. So this is the problem of CKD diagnosis. That is why meetings like this makes a lot of sense, to make awareness to the public that this is a problem. This is how you got to get screened. This is how you should do. Next slide. So if you look at Indian numbers, you can see almost 2 lakh population is on dialysis, and the numbers keep growing up on 10 to 15% of CAGR, and almost 50% are seen at end-stage kidney disease. Next slide. So it is very, very important to understand that CKD is a progressive disease. Many times it gradually progresses, reaches in end-stage kidney failure, and it is too expensive to treat end-stage kidney failure, and their complications due to end-stage kidney failure are also too difficult to treat. The outcome may not be good, and they are too expensive. But and the risk of cardiac disease at every stage of kidney disease is much more. So this is very important to identify CKD early and treat it appropriately. Almost like 90% of patients with kidney disease did not receive proper care, and many of them, even who are started on dialysis, are stopping it because of financial reasons. Next slide. Next slide. Okay, so it is important to understand, like even in the Western world, diabetes is the leading cause of chronic kidney disease. 30 to 40% of our kidney disease patients have diabetes. Another 20-30% will have high blood pressure, and this is the reason where they land up in end-stage kidney disease a lot. So the numbers are doubling, likely to reach phenomenal proportions by the end of 2040. So about Indian CKD patient, there are some peculiarities. We have kidney disease patients at very young and productive age. Almost 50% are identified at very end stage. Many times have multiple comorbidities where treatment of them is becoming difficult, and the problem involves multiple organ systems requiring immediate dialysis need. Next slide. So there is huge amount of economic burden if you treat every ESRD patient. You can see the amount of cost. There is a massive amount of money which is needed to keep everybody on dialysis. You can see even our healthcare budget is around $3.5 billion, but the cost of ESRD, if you treat them properly, will cost you around $6.5 billion. So this is a cost that no country can afford. And every country should take efforts to prevent progression of kidney disease, identifying, stopping the kidney disease at the earlier stages, rather than thinking about providing them some form of kidney replacement therapy. Next slide. So generally, kidney replacement therapy is either dialysis or kidney transplant, but the important point is only 1 to 2% of our end-stage kidney disease patients in general population. In overall, in most of the centers, maybe 10-15% of our patients will get transplant. Almost 80% of them have to be kept on some form of maintenance dialysis for long, and the number are going up 10 to 20%, as I said, annually. And these number is also grossly underestimated because we don't have a registry. Many times, many deaths go undiagnosed, unrecognized, and not even come to nephrologist attention. Next slide. Next slide. Okay, so it is important to understand that previous slide, please. Okay, so it is very important to understand the cost involved. This is the data I have taken from our dialysis unit just to show you the impact of kidney disease on general population. To keep people on dialysis, people are selling their properties, assets, they are borrowing in money. Very few people have some money who can withstand on their own in terms of expensive care like end-stage kidney disease care. So that is why again we harp on prevention and progression and so on. Next slide. So how to identify early disease? It is very important. I told you in the early stages, there won't be any symptoms. Only by screening tests, we need to identify. So we need to identify a target population to whom screening tests can help to identify early kidney disease. So we need to identify the target population where screening of them makes cost effective. Next slide. So whom to screen for kidney disease? Anybody who has diabetes, high blood pressure, family history of kidney disease, obesity, prior kidney problems in patients with cardiovascular disease, smokers more than 40 years of age, people with low birth weight who are risk of future kidney events, and people with diseases, chronic diseases like autoimmunity, malignant disease. These are the people who have to get screened for problems with kidney disease. Next slide. So it won't cost you so much just to get screened for kidney disease. It needs an urine test and kidney ultrasound and calculation of estimated GFR using serum creatinine to know kidney disease. Next slide. So I am not going to detail about how to diagnose the kidney disease based on estimated GFR. Next slide. So it is important to identify kidney disease early in all diabetic patients. So every diabetic patient should undergo at least once in a year a urine albumin excretion test as well as serum creatinine to know whether there is presence of kidney disease. As I told, early kidney disease is asymptomatic. You won't be able to identify early kidney disease. You may look very much healthy. So please get screened and ask your relatives who are all diabetics to get screened for kidney disease every year. Next slide. So how to prevent kidney disease? It is, as I told many times, asymptomatic. So you need to identify kidney disease early by doing screening tests. Then for a general public, they should concentrate on blood pressure control, diabetes control, risk factor reduction in terms of weight reduction, avoiding smoking, avoiding nephrotoxic drugs, and primary treatment of primary kidney diseases, if at all, and proper following up with nephrologist in terms of medications and diet plan only will help to prevent kidney disease progression. Next slide. So these last few slides is about anemia and kidney disease. We know that anemia is a major important comorbidity in patients with kidney disease. As the GFR falls, the presence of kidney disease and the presence of anemia goes up to even almost 50%. Almost 50% of patients with end-stage kidney disease will have some form of anemia. Next slide. So it is very important to know the hormone that is helping in erythropoietin synthesis is generated from kidney. That's called erythropoietin. That is the reason to trigger or protection of RBCs in response to low oxygen tension. So not many people are aware that this is the hormone, the deficiency of which is the primary reason for anemia in kidney disease. Next slide. So there are many ways anemia can happen with kidney disease. It can be due to erythropoietin. Sometimes it can be due to reduced iron. It can be due to poor nutrition, which is very common in kidney disease. It can be due to blood loss also. So there can be many reasons which anemia can happen with kidney disease. Next slide. Then this is the last slide in the presentation about how to manage anemia. It is important that correction of anemia helps in stabilizing kidney function. And we need to think about identifying the cause of anemia and treating it appropriately. And the first step is always correcting iron deficiency in anybody with anemia. So if you have anemia in chronic kidney disease, we look at the iron status, then still after correction of iron status, if they still are anemic, they are given an erythropoietic stimulating agents like erythropoietin or any other long-acting erythropoietin and the newer group of drugs. This is how you manage anemia. So the last slide, next slide, is the overall conclusion. What we need to identify is the incidence and prevalence of chronic kidney disease is going up across the world, including in India. It's a silent killer, asymptomatic disease. So you have to screen for it to identify it. And it is CKD, prevention of progression is the key. That is possible if you identify at a very early stage. And the highest risk group are the people with diabetes and hypertension. This is where you need to focus on a lot of energy into. And these people are not only at risk of dialysis, they are at risk of more cardiovascular death. So that is very important that you address multifactorially, like weight reduction, blood pressure control, diabetes control, and so on, so that their overall risk profile gets reduced. With that, I thank all of you for your patient attention. And if there are any specific questions, I'll be able to take it. Thank you.
Thank you so much, Doctor. I mean, the data you shared with us is truly an eye-opener, especially in World Kidney Day occasion. We are so grateful to you for sharing us this awareness session. And I hope people take a lot from it, learnings from it. We have received a few questions from the patient community regarding anemia. So the first question that they've asked is that what are some of the current treatments in anemia related to CKD? And are they having some sort of side effects, or what is the pros and cons of it? And what are the future treatments which will be able to help in such a situation?
So at the moment, as I said, the predominant cause of anemia and kidney disease is predominantly iron deficiency, which has to be corrected with intravenous iron many times, because the oral iron, the tablet form of iron, is very difficult to be absorbed in kidney disease. And there is a problem, there is a molecule called hepcidin that prevents iron absorption in kidney disease. So it has to be given IV. That's what most of the dialysis patients or even end-stage kidney disease patients ask us. Why should we give injections? Can't we get with the tablet? So important point regarding iron is, as the kidney disease advances, because of hepcidin, oral iron is not absorbed. We have to take IV iron. The second part is, as I told you, about kidney is the major source of erythropoietin. If that is deficient, it has to be given as injectable forms. We have different forms of erythropoietin, long-acting, short-acting, medium-acting, and so on. So you have to discuss with your doctor about what is the best molecule for you. The third are the latest group of drugs. There are a group of drugs called prolyl hydroxylase inhibitors, which are a newer form of drugs, which are kind of oral drugs that are useful to correct anemia. So these drugs are, and now in the last 1 or 2 years only, they have been introduced. So these drugs might replace erythropoietin at some point of time as we get more and more experience on these drugs.
Thank you, Doctor. We had a second question, but I think you've already answered it in the first answer itself. We had a question which is related to, so anemia affects everyone. So how is anemia of renal origin different? So basically, so you answered. Would you like to elaborate a bit for?
So CKD anemia is different from the general population anemia. General population anemia is in general many times nutritional. It is more towards iron deficiency. Here, even if you correct iron and other nutritional factors, because of erythropoietin deficiency, these people's anemia will not get corrected. Then there is also some ongoing blood loss whenever, especially in patients on dialysis. So this is subtly different from general population anemia, which many times will require some form of erythropoietin stimulating agents.
Okay, so we have a lot of transplant recipients also in our community. So one question came up from that side. Like after transplant, especially in men, we have noticed that there is high HB and they have to do a blood donation for that. And in women, because of menstrual cycle, everything, the HB goes down. So many were confused about the causes of this and some solutions related to it.
So it is kind of these post-transplant erythrocytosis, means excess production of hemoglobin or red cells post-surgery. There is only theories to explain it. One of the major causes include tacrolimus toxicity. The second with generally is the general well-being that happens. There is always a source of blood loss in CKD patients. All that will go off as you become normal. And the negative feedback is not that stimulation stops, so people will have higher and higher hemoglobin. So that can be stopped to a certain level with certain group of drugs. So we give a certain group of drugs called renin-angiotensin system inhibitors to reduce hemoglobin production in some patients. For people who are to have very high hemoglobin, who are at risk of blood clotting, we recommend them at the initial phase sometimes venous section, means ask them to therapeutically give some blood donation so that the hemoglobin comes down.
Thank you so much, doctor, and thank you for answering our questions, and thank you for this wonderful, informative session for all of us on the occasion of World Kidney Day. And I'd like to thank you on behalf of Kidney Warriors Foundation. Thank you so much.
Thank you.